Reengineering Management, Survival, Revival, and Growth, where health is one of them. This 90-minute session of health sector will start with a presentation by our moderator to set its foundation. It will then proceed to panel discussion of questions raised by the moderator based on the context of reengineering management in health sector. After each discussion, the floor will be open to the participants to present their queries to the panelists for a few minutes. At last, the panel discussion will be wrapped up by our moderator. Without any further delay, let's introduce and welcome our moderators and panelists on the stage through audio-visual presentation. First of all, we have our moderator for the session, Dr. Bhagwan Koirala, Chairman, NMC, Chief Surgeon, TU-IOM. He is widely known for pioneering open heart surgery in Nepal, who was also awarded and recognized by various institutions like Madan Bhandari National Award, Youth Asia, Manager of the Year Award, Science and Technology Talent Award, Grade A, and many more. Please help me welcome Dr. Bhagwan Koirala on the stage. Now, we have our panelist, Dr. Basant Pant, founder and chairman of Annapurna Neurological Institute and Allied Science. Dr. Basant Pant, Vice President of Asian Congress of Neurological Surgeons, Professor and Department of Neurology at KISS Medical College and Tribhuvan University, Kathmandu. He also served as an editor of Journal of Nepal Medical Association. With years of experience and multiple surgeries, he has published more than 60 articles in peer-reviewed journals. Please help me welcome Dr. Basant Pant. Now, we have Dr. Hector Gayares, Chief Executive Officer, Scheer Memorial Adventist Hospital. He is former CEO of Adventist International Health System, Philippines, and has also been supervising 10 hospitals in the Philippines. He was awarded as the Most Outstanding Physician, Philippine Medical Association, Alumni in Leadership. He is also a fellow in Philippine College of Surgeons, Philippine Association of Laparoscopic and Endoscopic Surgeons, fellow of Philippine College and Hospital Administrator. Please help me welcome Dr. Hector Gayares. Moving forward with the panelists, now we have Professor Dr. Madhu Dixit Devkota, Executive Chairperson of Upendra Devkota Memorial National Institute of Neurological and Applied Science, Banswari. She is public health policy and management expert, has worked tirelessly in medical and public health education at the premier medical institute of the country. She has also drafted over 10 health policies and strategies for the government of Nepal, pertaining to safe maternity, infant health, and nutrition. Please help me welcome Professor Dr. Madhu Dixit Devkota on stage. Finally, we have Dr. Sanduk Ruit, founder and executive director of Tilganga Institute of Ophthalmology. Dr. Sanduk Ruit is an international figure for his extraordinary contribution in introducing low-cost and effective intraocular lenses for small incision contact surgery. He has been nicknamed as God of Sight for his life-transforming contact surgery to the poorest population. Moving forward, I would like to request Mr. Milan Gurung, Organizing Committee Member, CEO Conference 2022, to felicitate our moderator and panelists with khadas.
Yes. Thank you. Thank you.
Thank you, sir. Our panelist, Dr. Sanduk Ruit, will join us shortly. Moving forward, I would like to hand over this session to our moderator, Dr. Bhagwan Koirala. Over to you, sir.
Thank you. I think we're running late, so we would start right away. It's truly a pleasure and honor to be here today together with our distinguished panelists and to have this great audience. We have a lot of expertise in itself and in yourself. Today's session, as Management Association of Nepal has dedicated to health sector, which doesn't often happen within the Management Association, and it's good to see that the health sector is also taking a space in the overall management sector of Nepal, and we're really feel good to be here. The way we have organized today's session, I think she outlined a little bit, is that I'll set the stage by raising certain questions which our panelists will touch upon, and not every panelist will give the same weightage to every question the way I present it. They have the liberty to focus on certain areas, but we want to have some answers to those questions that we will raise. And these questions were circulated before, and you could also go beyond any issue that touches the health sector and either works as a barrier or has a potential to help the health sector of Nepal. After I set the stage, and I'll invite each panelist to talk for 8 to 10 minutes. You may use your slides. And then we'll go for a round of questions from the audience, and we'll try to make it as interactive as possible. And then again, I'll go for a second round with the questions from the audience, and we'll go for a second clarification round to the panelists. I think that will wrap up the major part of the session. Then I'll, with my rapporteurs, will compile what you have said, and with the feedback from the audience, then we'll make a summary of today's session and present in the final session today, late afternoon. So I'm glad to be part of this session and be able to moderate this. Rather than myself talking on the issue, I'll gently highlight. Can we display them, or I'll just read it out from here. Glad to welcome Dr. Sanduk Ruit. You heard his introduction. He actually does not need introduction, and I don't want to invite the MC again. He is the founder and the executive director of Tilganga Eye Institute, and you've heard 1,000 times about the performance of Tilganga and Dr. Ruit's work. So let's not go back to this, but we would rather wait to listen from him afterwards. Okay, the initial question that we're raising today in the health sector is that our constitution says health is basic health is a fundamental right of the people. And no emergency should be turned down from the gates of the hospitals. And all people should have equal access by definition to healthcare, not necessarily free, but access. And COVID pandemic has posed several challenges in realizing this constitutional vision. Of course, we were struggling before that, but COVID has exposed the weaknesses and the weak links of our health system. It's critical to expand and continue on the service coverage, as well as improve upon the quality of the care that the Nepalese hospitals and institutions are providing today. And private-public engagement is equally important to realize this agenda. So our question would be to the panelists: how do you see this happening in Nepal in terms of making the constitutional vision realistic? I think that would be the very first setting stage question to us. Next question we'll be asking to ourselves, and of course we'll try to find some answers from you guys, is how did COVID-19 affect our health system, particularly the institutions that you have served in? And your comment on the government policies and the role of the government during that time, particularly focusing on helping on the healthcare capacity building and crisis financing and solid partnership between private non-profits and public institutions. So that would be our second point that we want you to, share with us. How did this pandemic affect the relationship between patient, doctors, and health professionals and healthcare institutions? Is the fee structure a burning issue here? That exposed our relationship pretty badly in this scenario. I don't think that's the only case, but I'll invite our panelists to touch upon those questions. How can we uplift the current condition of the public institutes in the country? I'm partly responsible to answer that question. Maybe I'll do that at the end. But how do we see the possibility of quality control protocols in private and public institutes, and what might be the way forward in those areas? Is there a lack of concern in other areas that we call the social determinant of health, which determine the health status of the people? And major issue now in the health sector is the out-of-pocket expenditure that people have to pay from their pocket when they go to healthcare institutes for service. And one of the major reasons for poor relationship between doctors, healthcare workers, and public is because they have to pay a lot of money at one time, and while there is no certainty that the patient is going to get better. So the payment modality is very primitive in our country. And how do you see that national health insurance policy can be implemented effectively in Nepal? Is it a possibility that private institutions that can take on? What could be done to really make insurance in general practicable and possible in Nepal? Because I see without that, we really cannot achieve universal health coverage. And one of the last questions we keep raising for the last 20 years, hasn't happened much. Dr. Ruit has contributed significantly to this medical tourism, which is largely a rhetoric as of today. But is it possible? If yes, how do you see that happening in Nepal? Is it realistic? What are the regulatory issues that are blocking us from getting those? And mind you, India's average living standards were not that better, not even today better than Nepal's, when they started actually providing service to many international patients. And India has about $6 to $8 billion worth of transactions in healthcare tourism. Is that something, shows up in the end of the tunnel in Nepal? And finally, one possible thing that we might raise, ask you to highlight on, as I said, you can choose any of the focus area you think is important for you. What are the policy challenges to private and non-governmental institutions in Nepal, and what could be the possible solutions if you have any? So these are the broad questions that we set it up for you to look at. I'm sure you already have presentations ready, so I don't expect you to kind of change everything and focus on those. But for the audience, as well as for the panelists, these are the areas we want to have some answers for ourselves and try to present in the general session. So with this, I would invite the panelists to give your short talk. We know this is short time. There can be so many things that you could bring up, but the ability to make it concise is also an ability of the speaker. So we'll ask you to finish up in 8 to 10 minutes, and we can come back to the topics afterwards. So who do we start from?
So as Dr. Koirala has said, basic health is the fundamental right of the people. This is said by the Constitution. And our political slogan has been, your health is the responsibility of the government. Don't worry, I will look after your health when I am elected. तर हेल्थ भनेको नि एक-एकजना व्यक्तिको आफ्नो रेस्पोन्सिबिलिटी हो, एउटा फ्यामिलीको रेस्पोन्सिबिलिटी हो, एउटा सोसाइटीको रेस्पोन्सिबिलिटी हो। र संसारभरि जति पनि ठाउँमा हेल्थ अगाडि आएको छ त्यो भनेको कलेक्टिभ रेस्पोन्सिबिलिटी सबैले लिएर हो। यो कुनै पनि गभर्नमेन्टले मैले हात उठाएर हेल्थको रेस्पोन्सिबिलिटी मैले लिन्छु भनेर यो हुन्छ जस्तो मलाई लाग्दैन। नेक्स्ट स्लाइड। अब कोभिडको जस्ट मैले टच गर्दाखेरि मेजोरिटी अफ इन्स्टिट्युट कोभिडले गर्दाखेरि तल गएको छ, स्पेसली इन टर्म्स अफ द रेगुलर वर्क फ्लो द्याट दे वर डुइङ and maybe financially also they have gone down. तर अब कति इन्स्टिट्युटहरू चाहिँ they have actually thrived during COVID period because of the smart decision that they have made, or maybe they have changed their gear into treating more COVID patients. So there are many institutes which has actually done well. मेरो इन्स्टिट्युट चाहिँ अब म अरूसँग डेटा त छैन नेक्स्ट, तर मेरो इन्स्टिट्युट चाहिँ अब न्युरोसाइन्सको इन्स्टिट्युट भएकोले गर्दा इट वाज नट एफेक्टेड एज सच इन अ बिगर एक्सटेन्ट. तपाईँहरूले देख्नुहुन्छ 2 big dips in the work output. That was during the strict lockdown period. Otherwise, it has done smooth work throughout, and we never closed down our institute during the COVID. Next, please. So, एउटा चाहिँ के छ भने हाम्रो हेल्थ इन्स्टिट्युसन भनेको 4वटा पाङ्ग्रा छ. 4वटा पाङ्ग्रामा treatment is only one part of it. There is public health issues, there is academic issues, and there is research issues. All these has to be equally taken into consideration by each institute, whether it is a small clinic or a big institute. Next. So our scenario is, I travel a lot around many countries, and I see that our technology and the technique, the skill, the knowledge in our country is not bad if you compare it with many countries in the world. And technology is, we are introducing so rapidly. I say technology is just one telephone away. You just pick up the telephone and the latest technology will be there. It's, and the people, they are trained from all over the world. They are, they come back in Nepal. And we have a lot of knowledge from all over the world that has come to our country. I don't know whether medical service is a business or is it an ethical business? But I think every business needs to be ethical business. There is no business which has no ethics in it. And we have separated the institute in our country into public, private, and maybe NGOs. But I think this is arbitrary separation only. There are many countries where you can choose to go to any institute, whether it's a private or a public. You pay the same amount of money because that's covered by the insurance. So how do you choose an institute? You choose the institute by its service, not whether it's a public institute or a private institute. So, and one of the major problems that I've seen is that, there is not prioritization of health system in our country. Like, we are giving a lot of emphasis on non-communicable disease right now, like cancer. For neuroscience, they are giving emphasis on Parkinson's disease, which I do not agree. For Alzheimer's disease, and they are giving more emphasis on dialysis rather than trying to do a more transplant surgery. So, I think there is a lot of discrepancy there as well, how to prioritize our medical service. Next. And about management, we are quite good in technology and technique, but we are pretty backward when it comes to management. So I'm very happy that I'm here, and I want to learn a lot of things here. And this is because we are not taught, doctors are not taught about management. And I think it's a high time that doctors in medical education system, we should incorporate management, and especially in terms of economic management as well. And insurance, as Dr. Koirala was saying, insurance is the only answer that will give health for all. But next, we started a national insurance system in 2015 from 3 districts, and our plan was to cover 100% in 5 years. And in 6 years down the road, we have only covered 20% of the population. That's about 53 lakhs of the peoples are covered. And of those insured, only 39% of them are taking any service from this scheme. Next. And the bad news is that the reinsurance number is getting down all the time, and then it was about 9% in 2018, and now it's 38%. So 38% of them are not reinsuring themselves because they have lost trust on this system itself. And that's a bad news. And recently, many health institutes have stopped accepting government health insured patients because their payment was not done in time. Just yesterday, I read a news about Nepal Korean Friendship Hospital, where they restarted, this national insurance scheme when the minister went there and said, okay, I'm going to pay. So if minister has to go to each institute to reassure them, then how is national insurance scheme is going to run? Next. Academy, there are a lot of problems in academy, but there's a big potentials. I was talking with Madhu ma'am just now also. I think there's too many strata for education system in our country. And so you do MBBS, then you do MD, then you do MCS, DM, whatever, PhD. So too many strata, I think. And we have about 2,000 MBBS passed out per year. And, but there are about 7,500 to 8,000 people who want to get into postgraduate education program. But only about 1,200 people get into a postgraduate program. So there's always a backlog of about 6,000 to 7,000 people who cannot get into there. And this, what are they doing? These 7,000 doctors, right now, they are in their home, they are studying for America or England or whatever. They should be out in the field and they should be working. But our system is such that, for many years, they are just studying. Next. It's like a Bombay train system. Next. And research, as we all know, research is so important in every field. And even so in the medical field, and no country can prosper without research and innovation. And there's tremendous potential of research in our country, whether we do outsourcing of research, where we take the theme of somebody else and then do the research here, or we do research of our own. But to start, I think there should be a mandatory system for all the hospitals to keep, electronic database system. Whether it's a hospital, whether it's a polyclinic or whatever. We should start from there. Then we will gather data. We can start mining data. And then only we will start getting some, resourceful, meaningful information. Next. And another plague that is happening in our country and also in China and also in India is the safety of working environment. There's a lot of problem. Dr. Koirala also just mentioned. Mainly it's financial because they are not insured. They have to pay from their pocket. So there's a lot of doctor-patient problem all the time happening. So we need to educate the public. Public, what they think? The public think that if you go to a good doctor, a good big hospital, and pay all the money, then you have to be cured. This is the mentality that's happening. And death, it used to happen at home or in riverbed, but now people are coming to hospital, and the hospital is becoming a place for death. But the concept has not changed. People still think if you go to hospital, you will be cured. So we need to educate, and we don't have a medical audit system. We need to audit each hospital in terms of medical outcome of what is if somebody is doing cataract surgery in Tilganga, somebody is doing in another institute, it should be at par, at least to some extent. But there's no audit at all in our institute. We are only auditing the size of the room, the number of the toilets, things like that, but not the outcome of the health. And there is no cross-referral system, so you can keep all the patients to yourself all the time. There is no obligation that you need to refer. There's no referring channel that has been developed. The last one is mainly for the educate, regulate hospital and doctors on patients' right, and punish the wrongs. We have not punished hospitals or doctors who have done wrong. This is also a big problem. If they have actually done wrong, then they need to be punished. And security in a hospital in the terms of jail without bail, which the young doctors have been saying. Next. So informed consent is very much lacking in our country. The left side is just a consent which says, "Ke paryo bhane doctor jawabdehi hune chaina." That's all. This is just a consent. There's no information. So we need to develop a national protocol of at least, this much of information must be given to a patient before you take them to medical treatment. So next. So at the end, medical tourism in Nepal, I also think that there is a very big potential. If somebody wants to, if let's say the payment of the service is same, the quality of outcome is same, and somebody wants to go to Delhi, everything is same, and somebody wants to go to Pokhara. If there's a comparison, I'm sure a lot of people would like to come to Pokhara for treatment, but everything has to be same. And this is, already defined in this thing. And another thing is the alternative medicine. We always forget about alternative medicine, but alternative medicine, there's a very, very big potential of alternative medicine, medical tourism, which is actually already happening in Nepal, like for yoga, for meditation, for naturopathy. People have, are coming from the West. And this also we need to, explore. But then, there is poor coordination and cooperation between Ministry of Health and Tourism, and lack of specialized human resources, lack of information gathering system, and above all, when we say international hospital, actually international hospital means it's like, there is no, it's an international place, so you can use any money there. It's just like a transit, In transit, it's not a nation. It's an international space. So international hospital is like an international space. But we have never developed. We just have a small hospital which we name international hospital. But we don't have any regulatory mechanism or legal mechanism where there's a lot of international hospital coming in China right now. Germans are going and making, international hospital in China because they have got a fantastic infrastructures. I think I will end here. I think I have passed my time also. Thank you very much.
Thank you, Dr. Basant. Quite elaborative presentation. So there are very important points that you have raised, and I think we'll touch upon those points once again. Let me invite next Dr. Madhu Dixit Devkota. Of course, she will touch upon many of the points that Dr. Basant said, but she will focus more on managing hospital, and there is a big challenge posed to our health institutions that we don't have a good healthcare management. That's why our public institutes and even private institutes fail. So she would focus more on that, but welcome.
Thank you so much. Thank you, organizers. Thank you, Moderator, Professor Koirala, respected panelists and audience. I was smiling when Dr. Koirala was making his opening remarks, because those are truly public health problems which we've been grappling over I don't know how many years, at least certainly 30 years that I've been engaged in public health. However, to do justice to the time allotted to us, I would like to focus on my presentation, my presentation on my experience as the executive officer of Upendra Devkota Memorial National Institute of Neurological and Allied Sciences. I would be very happy to respond to some of your questions in public health when the moderator allows me, or when it's a really burning question that I can't stop from responding. Today, the topic, it may be a little surprising, but Dr. Pant has already highlighted how, there are so many problems in health and private hospitals, and COVID brought in some totally unexpected challenges. But I would focus mostly on how the COVID-19 situation was a catalyst for our institute for re-engineering management. And I thought that would perhaps do justice to the theme of this conference as well. So next slide, please. So basically, hospital management lessons. Next slide, please. Okay, so what was good about our experience? I think what was good was collaboration. We had the opportunity to collaborate with Government of Nepal, Ministry of Health, Department of Health Services, its divisions. That was really good for planning response, for planning immunization. I have to thank Epidemiology Division for coming and talking to us about contact tracing, which helped us, Shukraj Hospital, please, you've taken me back. You've taken me back. CCMC, Nepal Army, NGOs, Avishkar Center, hub and satellite groups that government created. Teaching hospital was the hub for us, and that was a very novel experience. What could have been better? Next one, please. What could have been better is if this collaboration was sustained. There was one meeting, and that was it. Thereafter, we were left to our own devices, basically. So there was a question about the capacity building effort, either from partners or government, nothing of that sort. Our traditional professional organizations, our umbrella organizations, could have a stronger presence, I felt. And I do not know much about the government sector because I've been away from it for the last 3.5 years. But private sector, actually, you felt pretty isolated and left to your own devices. Next slide, please. Okay. Dr. Basant Pant has already highlighted, our also happens to be a super specialty neuro and allied center. And we had a very strong neuro team, but COVID challenge was that you needed multi-specialty reality. The matter was made worse because government did not put us in the list of those hospitals where COVID services could be provided. So almost like an existential crisis situation was created. But soon we realized that our patients, very sick neuro patients, were coming in who were COVID positive, who were COVID negative. And we had to cater to both these categories of patients. Would you be able to saw this? There was nothing in literature about how to give continuity to service. I've got no problem. So how to give continuity to our service, and very soon I realized that we have to devise our own strategy, and we have to plan parallel services for COVID positive and COVID negative patients. How did this re-engineering happen? We took this opportunity to make changes in our organization. We made changes in the patient flow, in the route in which the patients and their families came into the hospital. We took special care in engaging our team because there was no previous know-how. So, we engaged our team in devising appropriate strategies. There was a very strong component of staff welfare and support, which I took up, mental health support for our team, and networking and collaboration. So these were the major themes that guided this restructuring or re-engineering, as you would like to call it. So what were the organizational changes I did? We basically revisited the health professional shifts, and because there was no transport available for them, we changed their shift to 12-hour duty so that there'll be less shuttling needed. We also provided services in 7-day slots for health workers. So you would come into the hospital and work 12 hours each day. The following 12 hours you would rest in our facility in the quarters, and you would work like that for 7 days at a stretch, and then you would stay in the hospital premises for the next 7 days. You would have a PCR because you want to ensure that you do not give COVID to your patient, your family members. So the staff will all get a PCR done. They would go home. They'll rest in the family for 7 days, and then they came back after being tested negative in a PCR. Yes, it was resource consuming, but I felt that this was needed to gain trust of our health workers. Transport from home was organized. Similarly, the super specialists that we are handling we don't find them in great numbers. So those who were working, we had to safeguard their health. We had to do our best that they didn't get infected. So even they changed their schedule so that not all of them were exposed to the virus at one go. The nursing and housekeeping staff had full board in the hospital, so they stayed and we provided food and all the necessities. We ensured that though the PPE was in short supply, but we did our best. Beg, borrow, steal, whatever was needed, we did. We even went on to sew our own PPEs. A local tailor was very kind. He took our order, but he was working from a shutter. And seeing the shutter half open, police came and took him away. So we had to rush to the police station to request them to release so that he could continue making our PPEs. Our staff, themselves developed the visors. When they first came, it wasn't available in the market. We made our own sanitizers. So all that, the security people were checking temperature. It was, now it is happening everywhere, but in those days it was quite novel. So a lot of task shifting also happened. Mental health. At the very outset, we did a quick survey of our staff because, as we know, there was a lot of grief around us, there was anxiety, there was insecurity as to what may happen, what would happen to the family, whether they take the disease to their loved ones. So our in-house clinical psychologist came handy. She did a quick survey to see our realities, and when we realized that our staff were worried, we ensured that one-to-one counseling services were available for our staff who needed the help. Similarly, and these findings are being in the process of being published. With regards to the next one, please. With regards, this is our staff preparing the PPEs, preparing. Next slide now. So facility patient flow को लागि हामीले अस्पताल बाहिर एउटा tent राख्यौं. Stringent national and international protocols were enforced. Screening would happen in that tent, and then, depending on the findings, patients will be routed through different tracks. They were separate, the separate wards. Even we were running 2 ICUs, one for COVID positive, one for COVID negative patients. Similarly, wards were divided, cabins were divided. The track that the patients and their families, the doctors followed, were also similarly rerouted. The next thing I did was engaged our team, because we had no know-how. We engaged our team through open dialogue and consultation with the entire team, the doctors, the nurses, the housekeeping staff, the security, all the health workers, and no one was left behind. All voices were heard. this was not one-time thing. We had regular brainstorming sessions, and based on what we heard from them, we wrote our patient management and staff management protocols. So those were written down, and rolling it for implementation was easier because it was their ideas, they took the ownership, and they felt empowered about it. So that was really good lesson for me. We used technology for empowering our staff and for appropriate knowledge, because there was a lot of, fake news, or not really the evidence, but lots was circulating. So we were concerned about that. So along with telemedicine for our patients, for online consultation, counseling, we also created the platforms for management. So I had written M for management. So mobile phone became such an important tool for keeping all of us in touch. So all the meetings were happening through Zoom or online. All the information was being shared. There was a hotline for patients, the test results, which were immediately shared with the team so that the nurses, the doctors could, take the patients to the respective wards. So all that happened, and we are still using those. Enhancing, we took special care for enhancing communication with our patients. So there was a bit of fear that they may not, because so many nurses left out of fear and new ones joined in. So there was a concern whether uniformity could be maintained in such a situation. So we created leaflets for the patients, providing all the factual contents, which was kept in the wards, it was kept in the outpatient, in the lobby area, so people, depending upon their condition and interest, could make use of it, and nurses were asked to use it at the time of discharge, so that there was uniformity and standardized counseling given at the time of discharge. So along with this, it was a great opportunity for me because I could contribute towards neuroscience by introducing a biplane cath lab and starting neurointervention services at our hospital. And that was a huge a dream of my husband's, which I was able to do despite the COVID situation. As you know, COVID enhances the thickening of blood. रगत को थेग्लो जम्ने संभावना बढ्छ COVID भएको बेलामा. So a lot of patients came in with stroke, young people, 34-year-old, 40-year-old men and women. We were able to provide thrombectomy services and coiling as they needed. So this was very meaningful and heartening to me personally, that we were able to advance and introduce new technology and ensure quality of specialized care to our patients, and the services were never interrupted regardless of the COVID realities. So my take-home message is that I've clearly seen a shift in management paradigm. The traditional top-down, I'm the boss, you are my subordinate, I'm the doctor, you're my patient, I'm the doctor, you're the nurse. That kind of hierarchical top-down management we have totally abandoned during this time. It's mostly through dialogue, through empowerment, through ownership that we have managed our institute, and this has created a very enabling work environment and a lot of empathy and compassion within the team. And I'm just so happy to share my experience. Thank you so very much for your patience.
Thank you, Dr. Devkota. I think great learning experiences from COVID times, and I think adapting to the newer critical situations and newer challenges is what is management all about. But we'll come back to that, because I request our audience to make notes, and we'll allow you to ask questions to the panelists at the end of one round of presentation. And I'm also making some notes, and I'll have some questions. May I now request Dr. Sanduk Ruit to come forward and briefly present, give your ideas on key issues of healthcare system challenges and opportunities in Nepal. No, that's perfectly fine. That's not working anyway, so it's no point.
Can you hear me on the back?
Yeah.
Dr. Bhagwan Koirala, Professor Madhu, Basanta, and Dr. Hector, yeah, and my friends in the audience. That's fine, thanks. Yeah. First of all, I'd like to share with you a little bit about what we have done in eye care. And if you look at the situation of eye care in Nepal, about more than 30 years ago, the prevalence of blindness in Nepal was about 0.8%. 30 years down the road, we have been able to less than half it to about 0.35. And that's a great achievement. We must have done something wrong, right, at least, you know. So if I look back at some of the things, then I would like to share with you that it's very important that the health institution has an autonomy. I strongly believe in autonomy. If you politicize, and for that matter, we should stop politicizing right from us. It's very important. That's, you know, and then it's most of the eye care, in fact, all eye care in Nepal has been developed on the model of a social entrepreneurship. Not for profit, but social entrepreneurship model. Very classical business social entrepreneurship model, where quality assurance has been taken care of strictly, and a lot of audits are done constantly on management and also the clinical output. Team approach, very important. And we have a cross-subsidy model where patients who can pay, they will pay full, and challenging you to give very good service, very high quality. So you treat both powerful people and powerless people. And you have in your hands to subsidize that, so that there is no barrier for people who have no money to come. And if you look at the health service in Nepal right now, you have a big chunk which is run by the state. And we all talk about the problems in state: lack of management, bureaucracy, and I think a very important thing is lack of ownership. And these are all interrelated. And everybody who works in the state-run institutions will take it as a step in their career. I don't think they will really like to own it. This is one of the biggest problems with state-run institutions. And I also think that in the state-run institutions, although resource is not a big problem, but proper resource mobilization is a problem. And retaining good people, this is really very important. And never ever good people get retained in institutions which are run by state. I think that's, you know, right from the center to the peripheral area. And then that allows a lot of mushrooming of very smart, very efficient private sector, where management is very good, quality is very good, but still little poor people do hesitate to go in. And then that allows us to come to this model of social entrepreneurship model. And so I would like, if the government wants to come forward and share with us, I'm sure we can give them some advice. The things that Dr. Koirala asked about the COVID situation in Nepal, especially with eye care, and eye care during the COVID period was very expensive. With all the protocols and formalities, we had to spend a lot of money. And since all our institutions around the country run on sustainability, on patients' fee, so we were virtually led into a situation where the income of the hospital was generally less than 5%. And we had problem in meeting the operating cost of institutions. So that was the COVID situation. Now, of course, things are coming back, but it was difficult. So all the staffs came forward and decided to take less than they were taking. Yeah, but still it was a big problem. And then the other thing that I like to touch a little bit is on what Dr. Koirala said was medical tourism. I think this country, if it is managed properly, has tremendous potential for medical tourism, but it has to be managed properly. Medical tourism should be managed like a hospital, and like a hotel. I think lots of ambience and hospitality, you know. So I think there is a room for that, and how the state can mobilize their embassies and councils in their own countries, and that link can come in. And we already have a lot of people coming from outside outside Nepal, but we need to formalize that and make it into a very smartly run medical tourism. And regarding the government institutions, my belief is that I don't believe in free health care. I think health care should be affordable and accessible. I think if you provide free health care, it demands, or it provides, it leads to lack in quality, and it leads to corruption. So if you make the health care affordable by creating a subsidy, it'll be good, I think. So we need to create models of multi-speciality hospital in Nepal, which can run in similar principles: autonomy, cross-subsidy, quality care, ownership. And there is no shortcut to this, the medical personnel's getting paid well. I don't think there's any shortcut. And they should have faith and confidence in their future. Yeah. The other thing that I think is, it's a very complex how you're going to set up the healthcare in Nepal. The other thing that probably could do is most of the hospital infrastructures that are present right now in different provinces, I think we could start with one province and do a proper capacity building of a large hospital and its branches, and build the capacity on the principles that it can run well. And I think it's very, very important that a hospital has a good governance. And can I ask our CFO to come and tell a little bit about health insurance?
Sure.
He can tell a little bit more than I can tell. And the concept of health insurance, its importance is so much that I want to ask our Tilganga's Chief Finance Officer to say a little bit about it. All right?
Don't take more than 4 or 5 minutes.
Yeah.
All right. Thank you, Rasa. You done? Thank you very much. Yep.
Namaskar, respected moderator, respected panelists, participants, ladies and gentlemen. I'm R.C. Khanal. I'm a CFO of Tilganga, and thank you for giving me opportunity to say something about health insurance. I like to present something in Nepali. Actually, in health insurance, there is some strength and there is some weakness. In health insurance, all general public can enroll in health insurance scheme. That is good thing. And senior citizen, financially poor people, they can enroll in free. That is another good thing. And government and community-based hospitals, they are being sustainable. नेपालमा गभर्नमेन्ट हस्पिटल र कम्युनिटी बेस्ड हस्पिटलहरू खासै सस्टेन हुन नसकेको अवस्थामा यो हेल्थ इन्सुरेन्स स्किम आएर यसले चाहिँ मोर सस्टेन बनाइराखेको छ। यो एकदमै राम्रो कुरा हो। तर नेपालमा हेल्थ इन्सुरेन्स बोर्डले जुन किसिमले अपरेट गरिराखेको छ, यो हेल्थ इन्सुरेन्सको प्रिन्सिपल भन्दा बाहिर गएर अपरेट गरिराखेको अवस्था छ। र हेल्थ इन्सुरेन्स बोर्डमा पनि इन्सुरेन्सको एक्सपर्टहरू एकदमै कम हुनुहुन्छ। यो चाहिँ अलिकति यसको विकनेस भनौँ अथवा दुःख लाग्दो कुरा हो। र हेल्थ इन्सुरेन्स गरिसकेपछि नर्मल्ली जसरी अरू इन्सुरेन्स कम्पनीहरूले मेडिकल इन्सुरेन्स गरिसकेपछि रिइन्सुरेन्स गराउने एउटा प्र्याक्टिस छ। इन्सुरेन्स भनेको रिस्कको रिडिस्ट्रिब्युसन पनि हो र यो चाहिँ हेल्थ इन्सुरेन्स बोर्डले गरेको छैन र जहिले पनि गभर्मेन्टले त्यसलाई सब्सिडी दिनुपर्ने र बजेट छुट्याउनु पर्ने हुन्छ। र हेल्थ इन्सुरेन्समा कलेक्सन भएको अमाउन्ट डिस्ट्रिब्युसन भइसकेपछि जहिले पनि इन्सुरेन्स बोर्डले गभर्मेन्टको मुख ताकेर बस्नुपर्ने परिरहेको अवस्था छ, जसले गर्दाखेरि अघि डाक्टर साहबले भन्नुभयो विभिन्न अहिले अस्पतालहरूले दे आर नट एबल टु पे ब्याक टु हेल्थ सर्भिस प्रोभाइडर, अघि कुरा भइसकेको छ। अब यसमा के गर्न सकिन्छ, यो अहिले रिइन्जिनियरिङको डिस्कसन भइरहेको हुनाले मैले अलिकति रिइन्जिनियरिङसँग जोड्न खोजेको। रिइन्जिनियरिङ भनेको लिटिल चेन्ज मात्र होइन, लिटिल इम्प्रुभमेन्ट मात्र होइन, हामीले बुझेको रिइन्जिनियरिङ भनेको ड्रामेटिक चेन्ज हो। ड्रामेटिक चेन्ज ल्याउन कसरी सकिन्छ होला भने अब यसमा हरेक प्रोग्रामहरू आफैमा सस्टेन हुन जसरी जरुरी छ, यो हेल्थ इन्सुरेन्स पनि आफैमा सस्टेन हुन जरुरी छ। त्यसैले यो टोब्याको म्यानुफ्याक्चररलाई र हामीले लिकर म्यानुफ्याक्चरलाई योसँग जोड्न सक्यौँ भनेदेखि यसमा हेल्थ इन्सुरेन्स सरचार्ज लगाउन सक्यौँ भने 4-5% गभर्मेन्ट लेभलबाट डिसिजन गरेर हामीले इम्पोज गर्न सक्यौँ भने त्यो डाइरेक्टली हेल्थ इन्सुरेन्स बोर्डमा त्यो पैसा जान्छ। र अहिले जुन काठमाडौँ युनिभर्सिटी धुलिखेल हस्पिटलले पैसा पाउन सकेको छैन भनेर न्युज आइराखेको छ, पिपी कोइराला धरानको केस छ, अघि कोरिया फ्रेन्डसिप हस्पिटलको कुरा गर्नुभयो डाक्टर साहबले, त्यो केसहरू चाहिँ रिपिट हुँदैन। यो फन्ड म्यानेज गर्न सजिलो हुन्छ र यो हेल्थ इन्सुरेन्स स्किमलाई गभर्मेन्टको हेल्थ इन्सुरेन्स स्किमलाई सस्टेन बनाउन पनि सजिलो हुन्छ। र अर्को चाहिँ यो सिमेन्ट स्टिल इन्डस्ट्रीहरू जसले अलिकति पोल्युसनमा यो सोसाइटीलाई अलिकति पोल्युटेड पनि बनाइराखेको छ र यसलाई सोसाइटीभन्दा अलिकति बाहिर राखेर पनि चलाउन त्यत्तिकै जरुरी छ। यसले पनि आफ्नो प्रफिटको सर्टेन पर्सेन्टेज CSR कर्पोरेट सोसल रेस्पोन्सिबिलिटी अन्तर्गत खर्च गर्नुपर्ने एउटा बाध्यताकारी व्यवस्था म्यान्डेटरी प्रोभिजन चाहिँ गभर्मेन्टले ल्याउन सक्छ, त्यो एउटा गर्न सकिन्छ। अनि अर्को भनेको जुन अघि डाक्टर साहबले भन्नुभयो हेल्थ इन्सुरेन्समा चाहिँ टोटल पपुलेसनको ओन्ली 20% आर कभर्ड, यसलाई बढाउनको लागि चाहिँ के गर्न सकिन्छ भने सबै स्कुल टिचरहरूलाई चाहिँ हेल्थ इन्सुरेन्स स्किमको प्रमोटर या एजेन्ट बनाउनु पर्यो। एजेन्टको लागि 6-7% कमिसन दिइ पनि रहेछ हेल्थ इन्सुरेन्स स्किमबाट। यसरी सबै स्कुल टिचरहरूलाई चाहिँ म्यान्डेटरी प्रोभिजन एउटा राखेर हेल्थ इन्सुरेन्स गर्नुपर्छ भन्ने कुरा चाहिँ हामीले स्कुलबाट नै दिन सक्यौँ भनेदेखि पक्कै पनि सोसाइटीमा चाहिँ हेल्थ इन्सुरेन्स गर्नुपर्छ भन्ने एउटा मास बढ्छ होला जस्तो लाग्छ मलाई। र यो चाहिँ मेरो सामान्य एउटा सर्फेसली एनालाइसिस गरेर भनेको कुराहरू, यसमा अझ ब्रेन स्ट्रोमिङ गर्दै गयौँ भने अझ राम्रो कुराहरू गर्न सकिन्छ होला। थ्याङ्क यू भेरी मच, मलाई समय दिनुभयो, धन्यवाद।
Thank you, our CFO from Tilganga Eye Institute, Institute of Ophthalmology. Now I'll request Dr. Hector Gentapanan or Genta?
Gayares.
Gayares, okay. I'm sorry I couldn't pronounce you right, but go ahead and present your slides. We want to hear a lot from you. Hector was managing, a number of hospitals, more than 10 hospitals at a time in the Philippines before he came to Nepal. So he's got a lot of experience of managing hospitals. Unfortunately, I'll have to keep your time short.
Sure.
I will find some other time to, share your expertise and experience afterwards. But go ahead.
Thank you so much. Namaskar. How many of you here are managing hospitals right now?
Everybody.
May I see your hand? We are in a time, okay, thank you so much. Okay, we are in a time when it is just finished lunch and it's so easy to sleep. So, because you are managing hospitals right now and it has survived 2 years of pandemic, please stop the person next to you and say, we are surviving. Go ahead. Yes, go ahead. Stop your person next to you. We are surviving. Yeah, COVID pandemic is a great equalizer, as any pandemic or any crisis is. It is a great equalizer. However, in any time of crisis or disaster, what happens is the healthcare sector is the last man standing. If there's an earthquake, you will always realize that people will expect that the hospital will be standing while the rest of the buildings are down. If there is a pandemic, even though your workers are also sick, people are expecting that you will still accept all of them, right? So this is one of the biggest challenges we have in healthcare 2 years into this pandemic. But there are 3 lessons I learned after supervising 10 hospitals. I'm just here in Nepal for just 8 months. I arrived here last August 1, so most of the experience I will share with you on the pandemic will be coming from my experience in the Philippines. There were 3 lessons I found out. The first one is the hospital with at least some kind of reserves, monetary reserves, was able to tide through. So for CFOs who are here, your day's cash on hand is very important. If you have a day's cash on hand, say for example 60 to 90 days in your reserves, you are somehow well into that good position in times of disaster, in case there will be another spike or in case there will be another pandemic that may come. The second one is the quality of leadership. The quality of leadership I found out is so important because people were so demoralized during, and basically this is a new pandemic, so nobody knows what to do. But if you have a strong leader who can stabilize the ship, a captain who will say, just have faith in me and we will continue on together. Just like what Doctor has said here, that collaborate, talk to your people. So if you have that kind of leader, the quality of leadership, if we have good leaders, 2 of my 10 hospitals were able to tide over the pandemic operationally. Even the last one, just I think 5 months ago, bought another hospital in the midst of a pandemic. Just imagine that. So good leadership is the second lesson I want to bring up to you. The third is because there is a dip in our revenue, very important that strong leadership should be strong enough to contain the expenses. If we have those 3 operationally, then those are the lessons I can share with you when it comes to the pandemic. Clinically, number 1, you will get to realize that during the pandemic, hospital zoning is very important. So you have a different zone for your OPD, you have a different zone for your inpatients. Even in your inpatients, you have a zone for mix and you have a zone for critical, or maybe the third or the farthest zone are your clean patients. So hospital zoning is very important. This is the one that we have learned. The second one is infection control and prevention is still a major player in the hospital. And corollary to that, of course, is antibiotic use. But it is also during this time of the pandemic that infection control and prevention shone brightly during the hospital operation. So it's okay. Okay. So these are my takeaways for you. Investment in leadership, healthcare leadership, I placed there actually 3. Should be person with integrity, insightful, and innovative. Definitely, COVID has brought out these 3 I's, and another 3 C's that I always look for when I appoint leaders is character, competence, and charisma. You may have the competence and the charisma, but if you don't have the character, you don't have the integrity. You may have the charisma, as most politicians are, but they don't have the competence, and still we're going nowhere. So, those 3 are very, very important. For the questions of Dr. Bhagwan here about number 1, private-public partnership and all those things, I want to say that if there is investment in infrastructure with the best returns, what do I mean by that? Just like what Dr. Ruit has said, those who can pay, let them pay. And those gains from there, let it subsidize those who cannot pay. It's like the Robin Hood principle. So if we invest on hospitals that are really specialized and that they can, part of the profit can be diverted into into social care that will both improve what was the issue about medical tourism, because we will have very, very good hospital. At the same time, profits from this good hospital coming in, dollars coming in from abroad, then we can generate it into social care to those who cannot pay. For medical tourism, I want to point out the model of Thailand. Thailand has a different stratas of hospitals. They have hospitals for the general public, but they have really special hospitals for medical tourism. And I was there in one of their hospitals in Bumrungrad, and I was just so amazed with 2,000 to 3,000 outpatients from the Middle East coming to that hospital just for different kinds of treatments. So redistribution of resources, that will be my third takeaway. And my last, of course, is incentivized investment in healthcare. I read the annual report of the Ministry of Health and Population, and one of the biggest challenges there, I know it is a beautiful report, it has a beautiful plan, it has a beautiful policy, it has beautiful report, but there is one line there that says, budget allocation is the critical limiting factor in executing all of these plans, right? So, if the government, which is the primary, has the primary responsibility to take care of the health of the people, why not engage the private sector who has the money to come in and join and invest in healthcare? But of course, it's going to be, the question a while ago was, is it going to be for profit or not? But I also like the health policy of Nepal, because it says there, promote the paradigm shift in healthcare from profit orientation to service orientation. I don't know yet how to do that, but if there is a promotion for incentivizing investment in healthcare, at the same time coupling it with orientation from profit to service, I think they will all go together. So with that, I have several more slides, but I know time is not available for us. Thank you so much for your kind attention. Namaste.
Now we'll take questions from audience. You can direct questions to each panelist, or also ask very generic questions, and I'll redistribute that. So Bachu Kailaskani wants to ask one question.
Namaste. I have many questions in my mind while I was here. I'm here. First questions is about the presentations from Dr. Basanta. He raised many questions about the management of the healthcare institutions, training to doctors, research, clinical audits, and many things. I know that doctors are quite busy for clinical services. They provide the clinical services to the patients. This is their primary responsibility. In our country, I have realized that the most one of the most lagging factors is that the doctors are not motivated to carry out the research, trainings, healthcare governance parts like the clinical audit or research or the clinical effectiveness activities or the patient experience activities. So my questions here is in this regard, is how can we motivate doctors who are leading the healthcare organizations to re-engineer the healthcare institutions to carry out those basic functions of the medical fraternity in this country? This is the first question. I have second questions as well. Okay. The second question is about the regulatory body in the in this country. So what I feel is in this country, the Ministry of Health sets the policies for the healthcare institutions, for the health system and policy in this country. They also regulate, supervise, and monitor the healthcare institutions. So there is a conflict of interest in the system where Ministry of Health are the providers of the healthcare institutions, and Ministry of Health is also the regulatory body. Therefore, it's my rather suggestion that we need to have an autonomous, independent regulatory body to regulate the healthcare institutions and the services in this country. So again, my question here is, how can we make it happen? It is very difficult because I know that government, if government is motivated, we can make it happen. If political leaders are motivated to make it happen, it happens. But how can it make it happen? The questions can be answered any of the panelists.
Thank you.
Here. Thank you very much.
That's a general question for everybody. I'll address that afterwards.
नमस्कार मेरो नाम वीरेन्द्र काजी प्रानाङ्ग Bhaktapur Heart and Diabetic Center बाट just sharing experience about in the Bhaktapur case about the health insurance policy which are very much applied in the Bhaktapur district in various hospital. But as we are dealing in the diabetes patient and heart patient especially in this our clinic, most of the patients do the health insurance for taking the medicine who are regularly taking the chronic medicine for the chronic diseases. And as I found that most of the cases after going to the institution for who's providing the insurance services, they just go and visit for the taking the medicine, and there is no regular ratio of the medical professional versus patients. Before the insurance established in the hospital, those number of medical professionals as it is, but the patients number is increasing. So it's required to the ratio of the medical professional versus the patients, as the patients are not getting the well trained from the service from the medical service provider.
Thank you.
Good afternoon. I am Dr. Ajong Gurum, Vice President for Academics in Scheer Memorial Adventist Hospital, Banepa, Kapre. My question is to Dr. Santos. He pointed out that in the medical education, in the postgraduate, there are more than 7,000 or 8,000 people are interested to take the MD course, but very limited seats there available, only 1,200. Similarly, in the nursing course, it's been a drastic, very much problem. For the past 2 years, there is no students enroll in the BS nursing or BNS nursing, and out of 110 PCL nursings, last year it was only 30 institutions got the enrollment. So with this trend in Nepal, after 2 to 3 years or 5 years, there won't be any nurses to inject medicine in any health sector. So we have a BSc nursing that for the past 2 years, no students, and this year also, just the day before yesterday, there was a medical entrance examination result, and the result shows this year we will not be able to have the students too. So, how should we address this issue? And we have been to Medical Education Commission, Kathmandu University many times, but our complaints is not listened, not heard. So we are very much in trouble. So thank you so much.
मेरो नाम पिताम्बर अधिकारी, म तिलगङ्गामा काम गर्छु। मेरो क्वेसन चाहिँ अब सबै प्यानललाई, अब नेपालको संविधानले चाहिँ स्वास्थ्य सम्बन्धी अधिकारलाई स्थापित गरेको छ र ग्यारेन्टी गरेको छ भनौँ न। हामीले हेर्दाखेरि अहिले जति पनि हेल्थ इन्स्टिट्युसनहरू छ, गभर्नमेन्टको हेल्थ इन्स्टिट्युसनहरू पनि छ, अब सोसियल्ली यो कम्युनिटी बेस्ड पनि छ, प्राइभेट सेक्टरमा पनि छ। अब प्राइभेट सेक्टरको जुन किसिमको एउटा ठुलो इन्भेस्टमेन्ट र चाहिँ त्यो फ्यासिलिटिजहरू जसरी आइरहेको छ र अहिलेको नर्मल ट्रेन्डहरू, सर्भिसको क्वालिटीहरू सबै हेर्दाखेरि के साँच्चै एफोर्डेबल, एक्सेसिबल संविधानले जुन परिकल्पना गरेको छ त्यो किसिमको छ कि छैन होला। अब हुन त इन्सुरेन्स, अब यो हाम्रो क्रस सब्सिडीको कुराहरू, यो चिजले केही कन्ट्रोल गर्ला, तर योभन्दा केही एक्स्ट्रा मेजरहरू, केही तरिकाहरू चाहिन्छ कि भन्ने कुरा म राख्न चाहन्छु। थ्याङ्क यू।
धन्यवाद।
एउटा कुरा चाहिँ जस्तै अहिले के छ भने नेपालमा चाहिँ कतिपय मेडिसिन्स मतलब ट्रिटमेन्टमा चाहिँ नेपालमा सस्तो हुने रहेछ कि, जस्तै डेन्टलहरूको केसहरूमा, त्यो केसमा होइन, र यो अपर्च्युनिटी अथवा चान्सेसहरू जस्तै विदेशमा अब्रोड हुने मान्छेहरूले पनि नेपालमा आएर ट्रिटमेन्ट गर्ने त्यो खालको चान्सेसहरू कतिको छ, अपर्च्युनिटी के छ? किनभने हामी रिइन्जिनियरिङतिर गइरहेछौँ भने एउटा त्यो खालको छ। र अर्को चाहिँ
अघि बसन्त सरले भन्नुभएको थियो अल्टरनेट मेडिसिनलाई पनि अलिकति प्रमोट गर्नु पर्यो भन्नुभएको थियो र यसमा आयुर्वेदिक एलोप्याथिक के अरे होमियोप्याथिकहरू टिबेटियन के पनि भन्नुभएको थियो अर्को होइन र अल्टरनेटिभ मेडिसिनमा हामी के देख्छौँ भने त्यो बसपार्कतिर पहिला त्यो मुटुसुटु निकाल्ने त्यसपछि के गर्ने लास्टमा च्याउप्रास बेच्ने त्यो खालको कल्चर पनि छ र त्यो चिजहरू कन्ट्रोल कहाँबाट हुन्छ र त्यसले चाहिँ रियल्ली अब हामी त भनिरहेको छौँ रिसर्च डेभलपमेन्ट गर्नु पऱ्यो त्यसको क्वालिटी कसले हेर्छ होइन पब्लिक हेल्थले त्यसले डेफिनेटली त्यसले त इफेक्ट गर्छ होला रियलमा त्यो मेडिसिनले काम गर्छ कि गर्दैन भने यो खालको चाहिँ यसको रेस्पोन्सिबिलिटी कहाँनिर हुन्छ यो स्पेसली भगवान सरलाई नै प्रत्येक सोसाइटीले एउटा हस्पिटल खोल्ने आर्मी हस्पिटल पुलिस हस्पिटल अहिले त ब्याङ्करहरूको हस्पिटलको पनि कुरा आइरहेछ भोलि इन्सुरेन्सको अर्को हस्पिटल कुरा आउला के यो चाहिँ राइट प्र्याक्टिस हो त सरहरूको ओपिनियन के होइन र अर्को चाहिँ हामी जुन हस्पिटलहरूमा फाइनेन्सिङ गर्छौँ एज अ प्रोजेक्ट चाहिँ हस्पिटलहरूमा उनीहरूको प्रफिट एन्ड लस एकाउन्ट ब्यालेन्स सिट हेर्ने हो भने मेजर एमाउन्ट चाहिँ सेलिङ एन्ड डिस्ट्रिब्युसन हुन्छ कि इभन कस्ट अफ गुड्स सोल्ड भन्दा पनि हाराहारीमा सेलिङ एन्ड डिस्ट्रिब्युसन हुन्छ यदि सरहरूले चाहिँ जेनरिक नामबाट चाहिँ प्रिस्क्रिप्सन गर्नुभयो भने त्यो त पब्लिकलाई त अल्टिमेटली बेनिफिट हुन्थ्यो होला नि त होइन त्यो खालको छ अनि हामीहरूले हस्पिटलमा फाइनेन्स गर्दाखेरि एउटा के पनि देखिन्छ भने कस्ट ओभररन हुन्छ कि एउटा मेसिन हुन्छ अनि 2 महिनापछि आउनुहुन्छ अर्को मेसिन भनिराख्नु भएको हुन्छ किन हजुरले यसरी चाहिँ प्रोजेक्ट म्यानेज गर्नुहुन्न त भन्दाखेरि होइन डाक्टर साहबले मान्नु भएन भन्नुहुन्छ कि सरहरू टेक्नोलोजीसँग जुन यता इकोनोमिक बेनिफिट र टेक्नोलोजी पनि जोड दिनु पऱ्यो कि सरहरूले यति नै हो सर
थ्याङ्क यू मैले अब I'll try to assign the questions to each of the panelists. लास्टबाटै सुरु गरौँ यो अल्टरनेटिभ मेडिसिनको रेगुलेसनको कुरा त मै रेस्पोन्ड गरौँला त्यो र मेडिकल एजुकेसन रिलेटेड कुरा चाहिँ बट I'll do that at the end as part of summarizing. अहिले यो विषयगत अस्पतालहरू चाहिन्छ भन्ने इन्ट्रेस्टिङ प्रश्न आयो अनि यसमा डाक्टर दीक्षितले भर्खर जोड्नु भएको थियो यो चाहिँ नि कम्युनिटीको एउटा समुदायमा आधारित भएर बनाउने अस्पताल सिभिल आर्मी पुलिस अब शिक्षक त्यसपछि ब्याङ्कर्स मारवाडी अस्पताल लट अफ थिङ्स आर कमिङ व्हाट डु यु थिङ्क
झन्डै 25 वर्ष पब्लिक हेल्थ को नेपालको सिस्टम स्ट्रेन्थन गर्न त्यसको लागि एप्रोप्रिएट ह्युमन रिसोर्स तयार पार्न त्यसको लागि पोलिसी एडभाइजरी काम गर्न मैले बिताएको सो दिस इज समथिङ भेरी क्लोज टु माई हार्ट अब अहिले मलाई कस्तो लागिरहेछ भने हेल्थ इन्सुरेन्सको धेरै कुरा आयो हाम्रो एकदम राम्रो भइरहेको हेल्थ सिस्टमलाई हामीले अब इन्सुरेन्सको त्यसमा कुरा छिराएर भइराखेको पनि इट्स क्रम्बलिङ द्याट्स द रियालिटी अब त्यसमा चाहिँ अहिले फेडरल रिस्ट्रक्चरिङ र त्योसँग पोलिसी र अपरेसन्स रिलेटेड जुन इस्युजहरू छ म्यानेजमेन्टको त्यसले झन् कम्प्लिकेट गरेको छ मलाई चाहिँ कस्तो लाग्छ भने नेपालको पब्लिक हेल्थ सिस्टम एकदमै राम्रो छ म केही वर्ष अगाडि सार्स भएको बेला म सम्झिन्छु चाइनामा चाहिँ कर्फ्यू लाग्यो किन कर्फ्यू लगायो होला भनेर अचम्म लाग्यो मलाई र पछि त्यसो केही वर्षमा म चाइना जाने मौका पाएँ र त्यतिखेर मैले के देखेँ भने त्यस्तो हेल्थको उहाँहरूको पब्लिक हेल्थको इन्फ्रास्ट्रक्चर रहेछ हुन त हामी बेयरफुट डक्टर भनेर सिकेर हुर्क्यौँ त्यस हुनाले नेपालमा चाहिँ मलाई कस्तो लाग्छ भने हामीले हाम्रो जे स्ट्रेन्थ हो त्यसलाई वी हेभ टु क्यापिटलाइज अन द्याट एन्ड आई थिङ्क गभर्मेन्ट सुड टेक द रेस्पोन्सिबिलिटी हुन त अहिले भन्नुभयो कि मैले चाहिँ नोटै गरेको थिएँ ग्यारेन्टी अब हेर्नुहोस् कागजमा ग्यारेन्टी लेखेर के गर्ने almost 70% of the health expenditure is coming from out of pocket त्यो चाहिँ हाम्रो गरिब जनताको चाहिँ रियालिटी हो र धेरै जसो हामी कहाँ बिरामीहरू म एउटा प्राइभेट अस्पताल अहिले म्यानेज गरिरहेको छु कम्प्लिटली 3.5 वर्ष भयो बाहिरबाट पैसा नआउने हो भने रेमिटेन्सको हामी नेपालीलाई गाह्रो छ एकदम गाह्रो छ अर्को रियालिटी के छ भने स्पेशलाइजेसन सुपर स्पेशलाइजेसन त्यसको दौडमा हामी पनि लागेका छौँ म पनि लागेको छु साइन्स भित्राउनु पर्यो एडभान्स सर्भिसेस दिनु पर्यो नेपाली गरिब भएर किन एडभान्स सर्भिसेस नपाउने त बट एभ्रिथिङ कम्स विथ सच अ ह्युज कस्ट अहिले न्युरो इन्टरभेन्सनको सर्भिसको मैले कुरा गरेँ एउटा क्याथेटरलाई 3 लाख पर्छ यसलाई ट्याक्स अलिकति घटाइदिन पाए एटलिस्ट 18% त बिरामीलाई सहुलियत हुन्थ्यो भन्दा त्यो क्याथेटर चाहिँ कस्टम सहुलियतको लिस्टमा छैन. There are so many different kinds of catheter, you know. So यस्ता कुराहरू चाहिँ हामीले ध्यान दिनुपर्छ जस्तो लाग्छ र मलाई चाहिँ कस्तो लाग्छ भने there is government should take the responsibility of ensuring good quality basic health service, specialty को लागि collaborate with the established institutions, have the health insurance to as a safety net for people who are not able to pay. So I think that would be my
Thank you. मैले काइनीजीले सोध्नु भएको प्रश्नमा जान्छु. मैले दुईटा इम्पोर्टेन्ट कुरा उठाउनु भएको थियो. यो लिडरशिप ट्रेनिङ र मिनिस्ट्रीको कन्फ्लिक्ट अफ इन्ट्रेस्ट इन टर्म्स अफ providing service, developing policies and protocols, at the same time monitoring them. यो तीनटै काम मिनिस्ट्रीले गरिरहेछ. And that is a declared conflict of interest in terms of, you know, healthcare management. अब त्यसलाई च्यालेन्ज गर्न चाहिँ अहिले डिफिकल्ट नै देखिन्छ. त्यसलाई सब्स्टिट्युट खोज्न कहाँ जानु पर्यो भने त्यहीँ जानु पर्यो फेरि. when your boss has conflict of interest, then you have a problem. तर छलफल नभएको होइन. And नियममै ऐनमै QC agency बनाउने कुरा चाहिँ it's been advancing pretty well. So there is a realization. We need to segregate that money. But next point that you raised and others, अर्को question पनि थियो leadership को. Dr. Sanduk Ruitलाई म सोध्न चाहन्छु. It's a very genuine question. Hector presented in his talk. Invest in leadership. Leadership बनाउने कुरा चाहिँ healthcare को मलाई पनि one of the biggest potential area of investment लाग्छ. Because that's where we've been failing. And next thing is we have a lot of good examples of very episodic good management, but they don't last long. So that's how I think from your great experience and proven track record, international acclaim and records, how do we invest in leadership and how do we do the succession planning for leadership for an institution?
Difficult question. It's not a very easy, straightforward answer. And however, few things Dr. Hector shared. Leadership is like you are sitting in a glass box. You are transparent. You have to be transparent all the time, and that's how you can correlate with your team. And the second thing that I would feel is it's very important that you share your vision with as many people in the institution as possible. Yeah, I've always believed that we're talking about building hospitals. Building hospitals, infrastructures are not the solution. It's the software, the human resources, the ownership, the competence, the commitment, the focus, the integrity. That's present, and I have always believed that if an institution will run, then all your two hands, your 2 feet has to be inside the institution. It's not an easy thing to say this, but that's how if a leadership can create that scenario to all its people, I would say that he has achieved. And if he has shared and allowed the number of people working there to love and have passion in the work, half of his job is really done. So it's again, these are the things. And just to add on, I think we should stop talking about making professional hospitals, really. Making lawyers hospital and making Palana hospital, right? Rather than that, if you go down to the Tarai area, the healthcare, the state healthcare is so bad. Why not we have a structured capacity building? Do it scientific structured capacity building where you negotiate with the Ministry of Health that this is the way that you have to run. And have an autonomy. Yeah. Thank you, Rasa.
Thank you. I just want to support his idea. यो विधागत, विषयगत, समुदायगत अस्पतालहरू भनेको यो झुट हो, यो गलत हो. ब्याङ्करले गर्नु खोजे भए तपाईले हल्ला गर्दिनु होला. म्यानेजमेन्ट एसोसिएसनले पनि त्यो भन्दै हुन्छ. I totally support you. शिक्षक अस्पतालको पनि त्यही हो. Public institute fail खाने अनि अर्को नयाँ institute create गर्ने and that's going to fail and you do something else. So यो धन्दा बन्द गरे हुन्छ भन्ने मलाई पनि लाग्छ. हाम्रो institute बलियो भयो भनेदेखि चाहिँ government can give the privileges to the target population wherever the institutions are functioning. So thank you for highlighting that. अब let me come to Hector, referring to question from Vinay. Vinay, the cost of medicines. I mean, there are a lot of things we can talk about that. Nepal, Bhidre pani, there is very extremely variable pricing in the molecules that are very common. Generic terminology ma हामी धेरै debate गरिरहेको हुन्छौँ, and I see that as a very simpler question than what people make. But my question is, how did, what is your experience on trying to make the common essential drugs available to most people, at least through the national insurance scheme in Philippines? And does that concept of generic tablets, so to speak, is a practical thing, or it's more of a misnomer because you could reduce the price otherwise also? I think I know how to do that. What's your response to that?
Our experience about generic medicines is there is a strong generic law in the Philippines. So that's one. The second one is there is an MDR. It's MDR law. It's for certain medicines that are essential. There is a cap price for that. Then another agency of the government started what they call pharmacy of the people. In our language, we call it butika ng bayan. Pharmacy of the people. It has more than across the island, more than 5,000 branches. And they were selling all these medicines that are cheap. So there's the law that mandates generic prescription. There's the cap price for certain essentials medicines. And the government made it available across everyone where they can buy cheaper alternative. And with regards to health insurance, this one is you can reimburse, get the receipt and reimburse, but it's not totally 100% reimbursement, but somehow you get the reimbursement. And talking about health insurance, I should say that the government plays a very, very strong role in this. Expenses for healthcare per capita in the US is very high. It's $11,000, but it's not the number one healthcare system in the whole world. Expenses per capita for healthcare in Korea is somewhere between $2,000 to $3,000, and it's the number one. So I would say it's not the total amount that is there, but rather the expertise, finding the sweet spot where we can get maximum benefit for substantive resources. So that's, again, it goes down to leadership. You give much resources to somebody that does not know how to lead, those resources will be gone. But if you have a good leader, even with few resources, but very innovative, you will have a very good output.
Thank you. I think we addressed most of the questions that the audience had. म पछि तपाईको त्यो MEC को related कुरा अलि पछि गर्छु. I have a couple of questions to Dr. Ruit. The biggest challenge we face today is, even as a regulator, is hospitals hardly follow protocols, checklists, and that's been proven worldwide. And if we only follow a certain checklist in admissions, emergency turnover, operating room checklist, and follow the guidelines, the outcomes would be far better at the same price, same cost. I know you follow protocols, and that's why your institution has, tremendous track record. How important is that for all institutions? And in fact, I invite Dr. Devkota also to respond to that, to follow certain basic essential protocols in healthcare delivery. Enlighten us on that.
I think it's very important that you follow the protocols, and we would like to call that as steps and standard operating procedures. And you have guidelines right from the time that the patients get into your hospital till the patient leaves. And the whole cycle of chain of delivery you can address, and you can have different steps addressed at different time. And we haven't done the way we would like to. There are still problems. One of the things that we could do this well is there has to be regular internal and external audits, and that will allow these protocols to be in place and rectified time and again. The second important thing is, in an institution, I really think there needs to be a lot of good counselors, patient counselors. And in some hospitals it is but I think you have to invest in patient counselors, that they can talk to the patients, and but otherwise you can follow the whole protocol, the standard operating procedure for your surgery, for your examination, for academics, and everything. But basically, I think it is really writing down a standard operating procedure and following it. Right, sir?
Well, absolutely. Thank you. I mean, that's something that we need to pursue. I'll also, if you want to respond to that question, that's great. But I'll also ask you one more question. अहिले संसारभरि mostly low-income countries, including India, the turnover of staff is extremely high. And the colloquial language ma उनीहरुले अलि casual भाषामा Indian colleaguesहरुले भन्ने गर्छन्, the half-life of average healthcare worker is 2.5 years or something like that. So extremely attractive jobs in Australia, UK and US. How are we handling that? And Dr. Ruit he mentioned about retaining good staff is extremely important to give a good quality work. How do we address that in our institutions, given that there are resource constraints, but unless we retain the experienced ones, good ones, pay them reasonably well, I don't think it's possible to maintain the quality. Dr. Basant, you respond to the protocols thing and also the challenge of retaining staff.
Well, I don't think there is a cookbook sort of thing to stop migration, especially in nursing and also doctors. And I think it's also good. It's okay, I think, because I don't think you can stop people from moving from one place to another. You get a good facility, you get a good country, the U-turn will be there. We'll have brain gain very shortly. Those people who are going out are benefiting, maybe a few $100. If that can be earned in this country, then there will be a U-turn. So, we cannot double or triple the salary that we are giving right now. But the salary abroad is so attractive for the nurses. And I always say goodbye them with a handshake. And I say they should lead. And if my institute is taken as a stepping stone, it's okay. For me, it's okay. This is how I have taken. I want to answer to your question actually about how the four aspect of the health that we are supposed to deliver: academy, research, treatment, and public health services. These all four has to be addressed by all the institutes. But the treatment part and the economic part is the more lucrative one, more attractive one. So everybody is only going through, towards treatment only, and then, financial gain. But there is a lot of potential on research. And there is also money in research, because all developed country has become developed just because of research, So the only thing at this point of time, the only thing is we need to impose legally that all institutes must have these four, components in their hospital or institute or even a polyclinic. So this is what I think. And about just one word about generic, that is a very important point. Dr. Bhagwan also have a lot of ideas about how to reduce the price of medicine. We try to prescribe in generic. We want it, but there is a legal boundary and we cannot do it. Right now, generic is not allowed in Nepal. Indians have done it, and they have got generic shops, but in Nepal this is legally not possible. But then if you prescribe in generic, it will be almost about 50% cheaper.
Thank you. I think we're wrapping up. We're pretty much at the close of the session.
Can I ask you a question?
To me? Yeah, sure.
You mentioned about having written protocols for services.
Correct.
Written protocol for services. Yeah. So, when neurosurgery started in Nepal, it was something new. So everything was written, and that is what we inherited from Bir Hospital Neurosurgery Department, and that is in operation till date. What I'm finding difficulty is, and that is where I'm hoping to see if we can do anything through the council also, through regulatory mechanism, is engaging doctors in open morbidity mortality meetings. In auditing, it is almost taken as if you are asking for something which is not part of the job. The role of leadership is very important, I would not deny it, but that is one area I'm finding a real challenge, and I wonder whether there could be opportunities where we could work, if it is made. Paper writing happens in an institute when there is room, whenever there is opportunity for promotion.
I don't think I can go more in detail about that. त्यसैले त्यो सिट खाली भएको कारण चाहिँ it's not because people didn't want to, it's not because there were not seats. The initial trial of Medical Education Commission को काममा केही प्राविधिक समस्याहरू अनुभवको कमीले गर्दा भएको यो वर्ष अहिले ब्याचलरको एक्जाम हो, we still have to see. यो वर्ष पनि खाली भयो भने we will see that as a systemic problem. त्यसैले आजै त्यसलाई let's not jump into conclusion, किनभने I hope यो वर्ष चाहिँ त्यसरी सिट खाली त्यो विधाहरूमा एटलिस्ट जाँदैन होला. Last year I know certain reasons that I would not like to discuss in public. र अर्को आयुर्वेदको काउन्सिलको कुरा पनि उठाउनु भएको थियो विनयजीले. आयुर्वेदको कुराहरू चाहिँ अब फर्चुनेटली और अनफर्चुनेटली नेपालमा 5 वटा काउन्सिल्सहरू नर्सिङ काउन्सिल छ जसले नर्सको त्यही कम्पिटेन्स एथिक्स स्ट्यान्डर्ड्स हेर्छ. सेम थिङ विथ हेल्थ प्रोफेसन, फार्मेसी एन्ड आयुर्वेद. So this is a pretty fragmented regulatory mechanism. जसले गर्दाखेरि हामीलाई we have limitations, and that's why I've been proposing from the council itself, let's have joint monitoring teams. We created that mechanism, which is kind of slow to pick up. Joint monitoring team of health ministry and councils, and antar council samanvaya samiti. We want to make that legalized, so that if there is a problem, it's not just the doctor who is held accountable. There is a nurse, there is paramedic, there is lab, there is manager, generator off board. What the doctor is going to do there, There are a lot of other things. So we want to do that. There's a concept, people are responding but slow to take off. त्यसैले काउन्सिलहरू धेरै पनि छन्. लास्टमा दार्सले भन्नुभएको कुरा, I'm sure we could do something about it, because to bring out certain good results, भएका रेगुलेसन्सहरूलाई अलिकति मोडिफाई गरिकन इन्फोर्समेन्टको लेभलमा जानुपर्ने हुन्छ. So now we can put all of these issues as either incentivized with numbers or enforced somehow, including, let's say, maybe morbidity, mortality meetings certified by hospital managers. These are coming up, and we can start working on those protocols. So I think there is a lot of room for us to work together on, give some messages, otherwise we'll close the sessions. It was great interacting with you all. That's up. Anything that you want to say, Dr. Ruit? As a closing remarks, just a sentence or two.
मलाई खाली डाक्टर साहब मलाई के भन्नु मन लाग्छ भने नेपालको हेल्थको सिचुएसन हामी तराईतिर गए पनि हामीलाई फिल हुन्छ. It is so much of resources have been spent and so little has been done, and I know a lot of us don't have any ready-made answer for this, but I think we should look at building models of specialty hospitals in the Tarai which can actually deliver or do capacity building of existing hospitals. And there has to be an agreement with the medical fraternity, the ministry, and the government in the provinces. And this may be one solution, but I really don't know. Yeah, but I think the research one, I just want to say that you may think that research is not very sexy, you know, but I think some people have actually made a lot of mileage out of research, and you can actually do research. You can do innovations, and you can come out and really excel in your career with research. Thank you.
Anything, Hector, you want to add as a closing remark, quick, 1 or 2 sentences?
I just want to leave this word in the principles of TQM, Total Quality Management, same in reaction to your quality control principle. If you don't ask for it, you will not get it. So, ask.
Good. Asa?
I'm just a learner. I'm just a lifelong learner. This has been a very interesting session for me. And though COVID has posed challenges, but I'm sure together we'll move ahead, we'll conquer, and let's hope we are able to make the most of the challenging situations.
Thank you. Basant, last words to you.
मलाई चाहिँ लागेको इन्सुरेन्स स्किममा अलिकति मलाई भन्न मन लाग्यो। म अहिले पनि एउटा चाहिँ कोअपरेटिभ बेस इन्सुरेन्स स्किम चलाइरहेको छु। 30,000 मेम्बर छ त्यसमा। र मलाई लागेको चाहिँ यो हेल्थ इन्सुरेन्स चाहिँ प्राइमरी हेल्थ केयरको लागि नेपालमा ल्याइएको छ। यो गलत हो जस्तो मलाई लाग्छ। प्राइमरी हेल्थ केयर भनेको चाहिँ गभर्नमेन्टको रेस्पोन्सिबिलिटी हो। त्यो कुरा मिल्छ। त्यो कन्स्टिट्युसनमा राखेको कुरो मिल्छ। तर कुनै पनि मान्छे कुन बेला पल्टिन्छ, कुनै बेला चाहिँ उत्तानो पर्छ भने जुन बेला चाहिँ ल 2 लाख रुपैयाँ ल्याउनुस् अपरेसन गर्नु पर्यो भने पनि त्यो बेलामा पल्टिने हो। त्यो बेलामा हेल्थ इन्सुरेन्स स्किम चाहिने हो। 5,000, 2,000, 3,000 सबैले निकाल्छन् अहिले। एकचोटि चाहिँ मोबाइल चार्ज गर्न 200-300 रुपैयाँ सबै खल्तीमा छ कि आजभोलि। त्यसले गर्दाखेरि चाहिँ यो हेल्थ इन्सुरेन्स स्किममै हामी चाहिँ एकदमै धेरै फोकस्ड भएर काम गर्नुपर्छ जस्तो मलाई लाग्छ। र त्यसमा ठुलो पैसा पर्ने खालको ट्रिटमेन्टलाई सपोर्ट गर्ने खालको, जस्तो अहिले झन्डै 6 लाख जति मान्छे इन्स्योर्ड छन् भने चाहिँ त्यो पोसिबल छ। र अर्को एउटा सेकेन्डली मैले मेरो लेक्चरमा नि भनेको छु, यो प्राइभेट पब्लिक त्यसपछि आएर सेमी प्राइभेट एनजिओ भन्दा यसरी सेग्रिगेट गर्ने नै होइन स्वास्थ्यलाई। र जस्तै हेक्टरले अघि भन्नुभयो कि चाहिँ प्राइभेट इन्स्टिट्युसनले कमाउँछ भने उसले सोसियल सर्भिस पनि गर्ने स्पेस उसले क्रिएट गरोस् र पब्लिक इन्स्टिट्युटले पनि पैसा लिने ठाउँ होस्। जस्तै मैले चलाएको इन्सुरेन्स स्किममा मैले टिचिङ हस्पिटलमा गएर पैसा तिर्न जाँदाखेरि हाम्रो यो लिने ठाउँै छैन, त्यही भएर कहाँ लिने, यो त कसरी बिल काट्ने भन्छ क्या। त्यसले गर्दाखेरि चाहिँ सबै ठाउँमा चाहिँ सिमिलर टाइप अफ सिस्टम क्रिएट नभएसम्म यो डिस्क्रिपेन्सी चाहिँ रहिरहेको छ। थ्याङ्क यू।
Well, with this, thank you very much, our great panelists, a great interaction. Thank you, audience, for good questions. ल यति भन्दै यो सेसन यही wrap up गरौँ। MC, you have closing के छ? ल भन्नुहोस् छोटोमा, तपाईँ पनि टाइम देख्न दिनु। Thank you. Give a big hand to our panelists, please.
Thank you, sir. The conclusion and key takeaways of the session will be presented by our moderator, Dr. Bhagwan Koirala, at the closing combined session of the event. Once again, let's give a huge round of applause for our moderators and valuable panelists. Before we move forward to attend the closing combined session, we request our moderators, panelists, and all the participants to move towards Regency Hall for high tea. Thank you everyone for choosing to be in this session. We are really grateful for your valuable time and presence in this mega event, Worlding Present CEO Conference 2022. With this, me, Sujina Shrestha, signing off. Thank you.